Thank you, Jorge. Yes, delirium is frequent in ECMO patients. You'll see that kind of patients. It is an altered state of mind characterized by an acute onset, and it is fluctuating in its course. You can see cognitive alterations of thought and of understanding, lack of orientation, psychomotor alterations, agitation included, emotional alterations, irritability, fear, anxiety, sleep disorders, disorders or disturbance of the sleep-wake cycle, and also awareness alterations. As predisposing factors for delirium, we have a number of elements: neuroinflammation, oxidative stress, deregulation of the hormones, endocrine, and also sleep disorders. All these may influence in increasing the risk of these patients, and this can lead to the misregulation of neurotransmitters and alterations in neurons connectivity. And from there could be an acute brain insufficiency, in this case, delirium. And delirium is characterized by neurotransmitters alterations, an increase in dopamines, glutamate, norepinephrine related to anxiety, agitation, irritability, and in addition, reduced acetylcholine, which will lead to memory problems and deorientation. Also, sleep disorders, and in this case, a decrease in melatonin. You know, the melatonin regulates the circadian cycle, and then all these substances that are also involved, and that will be increased, and that can cause problems. As to other predisposing factors of risk for delirium, we can list some more. We have here patient care, ECMO itself, the catheters of the patient's organic failure of different degrees, cognitive functioning, the basic one. If it has previous cognitive failure, there could be delirium problems. The age, fragility, severity of the medical condition, basic psychopathology, and all this may be combined in one case or another, increasing the risk of delirium. And pain, sleep disorders will have an interrelationship and will influence each other. Pain, sleep disorder, delirium. In ECMO patients, there could be anoxia, hypoxia, characteristically, and this is characteristic. There are many alterations. You can see the values of the different elements and the arrows indicating whether it is increased or decreased. But we have not only this in the patient, anoxia, hypoxia, there could be an age issue, other problems, ECMO, infection, dehydration. So the profile of alterations in these patients is very diverse. And here we're talking about statistics. Prevalence, incidence. Prevalence is what you see when the patient comes to service, and incidence what the patient presents during service. In this case, in the ICU, where we find these patients, you can see the value. There is a prevalence of 7 to 50%. Huge variability. This is not in ECMO, it is in general in the ICU. And also an incidence of 20 to 82% during the service provided to the patient. Delirium has a number of profiles. There is hypoactive delirium, hyperactive, and the most frequent one is hypoactive delirium. As Dr. Jorge said, frequently the patient is referred to us because they say he has depression, even if he is on an antidepressant, but then they will evaluate him, and it's our duty to discard that it is not depression, that it is delirium. And in that case, we have to make the necessary adjustments. And here we have a hypoactive delirium, but the percentages are different. Hypoactive 66%, hyper is 7.4, and in the other group of delirium 25%. Risk factors, I have listed some already in the previous slide, but here on this graph by Dr. Charminoe from 2001. This is an ICU service, and these are the most common risk factors found. Benzodiazepines and opioids. Opiates. Okay. And we can see the list. We have visual hearing deficits, that's a risk factor, hyperglycemia, sodium alterations, mechanical issues, fever, age, depression, and other things.
We also have to take into account if the patient is at risk of delirium or has delirium. We have to look at the drugs that the patient is taking. We have to discard as much as we can, or we have to assess and avoid anticholinergics. In this case, avoid fluoxamide, benzodiazepines also mentioned, antipsychotics in inappropriate doses can cause problems in these patients, so we have to be careful with that. And that's important because the interaction of these drugs is important. These are the scales for agitation. The most used are the Richter scale and the Richmond, the RAS scale. And I will show you a study where this is used. Treatment challenges. Patients with ECMO often need sedatives. I'm not saying they have to be sedated, they need sedatives to decrease the consumption of oxygen. Patients on ECMO need oxygenation and they need help on this. And we have to facilitate synchronization. A patient with a ventilator, we have to decrease stress and the discomfort and prevent malposition or maladjustment of the device. Management of delirium with agitation and we typically say that the dexmedetomidine is effective. Ideally, the patient should have a RAS of 0, that is alert, normal at -1, slightly dizzy or sleepy, but it's not the case. This study measured sedation in patients with ECMO. These are statistics, very interesting statistics. In this case, most patients, when started on ECMO, up to 96% of these patients were deeply sedated. This is a Richter score, a score of 3. In this scale, it is very sedated with continuous infusions of midazolam, in this case 49%, propofol 18%, or both 29%. 98% had opioid infusions, fentanyl 93, and morphine 4%, and the patient may be under one or more of these drugs. The sedative dose in patients with ECMO and analgesia tend to be higher than in other patients, like, for example, patients with a mechanical ventilator. And with this help, you can see that the difference between the dose of midazolam under ECMO, propofol, and fentanyl in some cases, and in some cases they don't get this help. So per patient under the same trial, 64% of ECMO days were with profound or deep sedation. 58% was positive to delirium at some point, and 24% had agitation, also in a Richter scale with 6 points to 7, which is the maximum. 40% needed mechanical contention with a median of 3 days. All patients with ECMO, 49% received haloperidol and quetiapine, 76%. So the ranges change. I also talked about factors that affect the pharmacokinetics of the drug. You give the drug to a patient based on the guidelines, but there are things that can change the bioavailability, the rate, or that they are sequestered because of the device. So it depends on the drugs, the patient's disease, and the ECMO. These are factors that affect the pharmacokinetics of the drug or the drugs. And at the bottom, this is what can affect the ECMO. In this case, increased cardiac output. The patient has a fluid, is having this fluid intake, and with ECMO, the solution is perfected, diluting the drugs that are administered to the patient, and also the sequestering of the drugs through the tubes and the membrane of the device. Other factors that are very important. On the left-hand side, you see the degree of lipo solubility. Drugs such as fentanyl have the highest degree of lipophilicity. And we see midazolam, propofol, ketamine, lorazepam, Presidex used a lot. And on the other side, we see another important factor, lipophilicity 1 and protein binding. And these are other substances. Propofol is affected by this, by the protein binding. Then midazolam, Presidex is also affected, lorazepam, fentanyl, and morphine. These two factors are important, so we have to know how available the drug is for the patient. This is another paper from 2012 by Dr. Checa, the sequestration of drugs in the circuit, and they make comparison. We see morphine on the left-hand side, and after 24 hours, there are no differences in the medication concentration, and we compare it with the midazolam, fentanyl, and propofol. It decreases to less than 20% of the three substances, and we have to take that into account. In control patients without ECMO, this doesn't happen. The concentration was maintained stable. So the difference is significant for some substances and less for others. And in these charts, we can see some cases and examples. It might seem complicated, but in this case, you have the lipophilicity and the drugs that are used. Patients with ECMO, Presidex, and dexmedetomidine have a lipophilicity higher than other substances like venlafaxine and clinidine, and it binds to protein highly. There are specific trials that have measured that there are sequestration disorders with sequestrations up to 40% of the drug, which is significant. We can also see GABAergic sedatives in ECMO. We have to be careful with benzodiazepines and how deliriogenic they can be. It could be, in these cases, midazolam, because we've seen it in patients, and sometimes and they suspended and diazepam. Another one that doesn't cause such a problem is alprazolam, diazepam. With ECMO, they may not have delirium, and that could be an option. And lorazepam has doesn't really affect relaxation and breathing. So in with these drugs, their lipophilicity is lower and less sequestration. For example, lorazepam, 30-50, and with less lipophilicity. alprazolam. And analgesia and opioids and ECMO. This is what patients need for different reasons. And for example, drugs like quetiapine have a high rate of delirium and a moderate lipophilicity. Other drugs like morphine, they're not as lipophilic, and the sequestration isn't as high, from 4 to 40%. Of these drugs, gabapentin, pregabalin, there's a negative score here, and they're hydrophilic. In this case, there isn't much of a problem with these substances, and the valproic acid, and it has more lipophilicity, but there aren't specific trials. There's more sequestration for these drugs potentially. In hypnotics, the most used are melatonin. It's a sedative that regulates the circadian rhythm, and in this case, it doesn't bind to protein, and low lipophilicity. So the melatonin didn't cause a problem. And Zolpidem, there was a problem. The lipophilicity is 3, more than other substances. So if the patient really needs it, we need more, a higher dose. We see psychostimulants and less sequestration potentially. And this last part, this is another tool we have to help patients with delirium. In this case, it's the antipsychotics. So haloperidol causes less problems, potentially for sequestration. When given, it is often given to patients IV, and it produces less extrapyramidal effects. Other drugs that can be administered can be quetiapine, risperidone with higher lipophilicity, and aripiprazole in cases of hypoactive delirium, and higher lipophilicity of the drugs here that I mentioned, the antipsychotics. This is a Stanford protocol for the treatment of delirium, and there are differences, of course, if the patient is hypo or hyperactive in the delirium. In this case, antipsychotics. A patient with hypoactive delirium, it could be haloperidol, risperidone in the hypoactive, and aripiprazole is a good option because it has an activating effect. And for hypoactive patients, quetiapine isn't a good option, but it can be a good option for the hyperactive. And there are also drugs like melatonin that are useful to regulate the circadian rhythm, and drugs like rivastigmine, that is an antagonizes psychosteres, can be used for delirium, but it decreases acetylcholine in these cases. And opioids are recommended because they need them because of the sedation. Other drugs like dexmedetomidine could be used better and are recommended in patients with hyperactivity, because a patient with a hypoactive patient, we can decrease the dose or remove or suspend the treatment or the drug. So the drugs mentioned in the charts and in the previous chart, this is based on the Stanford protocol. These are the recommended doses. In this case, these are often used in patients with delirium and ECMO, like haloperidol. The doses are 0.5 milligrams IV at different moments, And it can increase, and antipsychotics, if it's better in specific patients, because it's like a quetiapine and 5 milligram doses in the morning, afternoon, and at night, because it has a sedative, a slight sedative effect. So I'm not going to mention all of them, but this is an example of the drugs that can be used. And there are several things to use in patients who have sleep disorders, agitation, or delirium in ECMO. Now I'm going to talk about the clinical experience of the psychiatry program, the liaison psychiatry program. This was carried out in the Hospital Jesus Muguerza in Monterrey, Nuevo León, since March 2021 to February of this year. These are patients, if it hadn't been for ECMO, they would not have survived, most of them. The hospital stays are variable. Some patients were over 100 days with ECMO. So they're long, high frequency admissions. So in our department, there were 19 patients, 6 women, 13 men, of which 5 patients were deceased, 218 consultations because we saw them several times. The mean consultation per patient is 11. The range is 1 to 24 with an age range of, a median age of 47, the youngest 21 and the oldest 68. These are geriatric patients. The diagnoses per patient, the median with a median of 3, and medications per patient. This also varied. They were taking a lot of drugs. The median is 18, but they can go from 9 to 31 in these statistics. That was the lowest. And as we also see the most frequent psychiatric diagnoses. We found anxiety symptoms. This is the incidence when we saw them the first time. Depression, in this case, 10.5%. Anxiety. Sorry, he's correcting himself. 11 patients had anxiety, 4 patients had delirium. It was the second thing that we found most. But we have to take into account here that when we saw these patients didn't have delirium, and they developed it while we were seeing them. This is a prevalence. And after that, other pictures like depression. And these are the non-psychiatric diagnoses, for example, pneumonia, hypothyroidism, dyslipidemia, or pericardial effusion. So this was our experience in our ECMO department in the Christus Muguerza. And now we're going to go to the conclusions.